All right. Hey there, y'all. Welcome today. My guest is Shannon Colthran. I'm trying to make sure I pronounce it correctly.
Got it.
And she is a board certified OBGYN and is a menopause specialist. So, welcome, Shannon. Can you tell the folks a little bit more about your background, your qualifications, what you do?
Sure. So hi, I'm Dr. Shannon Colthran. I'm a board certified OBGYN, as Lisa mentioned. I'm also a Menopause Society certified practitioner. And I've been private practice OBGYN for 15 years. And then recently have started a menopause specific gynecology practice called MenoStart,
Mhm.
which actually combines fitness and nutrition as well as medicine, GYN only practice. So I'm in Northern Virginia. I grew up here, went to the University of Virginia, and then medical school in Philadelphia, moved back down here, and I've been here since 2008, serving the community.
Fantastic.
Yeah.
So, why, if you're an OBGYN, isn't menopause already? I mean, you're specializing in that area. Isn't menopause already your area of expertise? Why start this other business?
Great question. So, yes, we are the women's healthcare experts, OBGYN. But a lot of obstetrics, which is the baby part, and gynecology is focused on, you know, the periods, problems around the periods, birth control, contraception, fertility, obviously pregnancy and birth, the surgical part of GYN, fibroids, ovarian cysts, all of those things. And menopause is part of that, but traditionally it hasn't been focused on even in OBGYN, which is crazy to say and think. In residency, we have 4 years of training after we graduate from medical school. Maybe one or two lectures on menopause, bone density, that kind of thing. And it's a function of, we train mostly on younger patients because older people have private insurance, kids, don't have to see residents. But also there's just not a lot of data. So as I kind of grew up with my patients, as I am becoming this age, I'm 48, and, seeing how kind of the traditional gynecology practice isn't really serving this population, started learning more about it and decided to do a practice focused solely on that. So,
Yeah, yeah. And on the one hand, it makes sense, right? Babies are important. There's a lot going on there, a lot to know. Diseases, disorders, again, very important, a lot to cover, a lot to know. But it does kind of blow my mind that up until our generation, it seems like people just were ignoring the fact that menopause happens. And, it's like it only happens to over half the population. Why would we
right,
pay attention to that?
right. And we're, 30, 40 years in menopause of our life. And as people are living longer, that number is going to expand as well. So I think there's a lot of factors to it that's so interesting. And that's why I love talking to people about it. Just, even non-medical people getting their perspective, and a lot of aging bias, a lot of, you're not supposed to age as a woman, right? And
Mm.
so of course we can't talk about menopause because that's admitting that we're old. Um, I think just not a lot of resources, and generationally, we haven't lived this long, and kind of I've seen a lot of quotes which I think are so profound that women's suffering is normalized, and that you're supposed to suffer in this time, the kind of stereotype of the grouchy, hot old lady, and everyone kind of laughs, she's the butt of the joke,
Yeah.
and that's menopause. And
Hot in
so,
the wrong way.
right. Yes. And so it's hard to, with that in mind, to be like, hey, I actually don't feel great and want somebody to help me. But yeah, we're changing that, which is great.
Yeah. Yeah.
Yeah,
And it's so true. My husband said this, and this was in a joking context. We were giving him a hard time for the man flu.
Right.
And he said, well, you have to remember women get a lot of practice with suffering. They're good at it. But men, like if everything's not functioning perfectly, we're like, definitely, I'm dying.
Right. Right.
Like that's horrible and also probably accurate.
So interesting. Yeah.
Like
Can you
it's a
imagine
big
if
deal
men
if
were
I'm in
pregnant?
suffering. It's like normal for you.
Yeah.
Like, thanks.
Yeah. It's interesting to
Yeah.
think of it that way.
Yeah.
Um, but we are more tied cyclically to our bodies, even through, obviously menstruation and that whole time, your body changes throughout the month. And so we are used to those fluctuations, I think. Men, not as much. But yeah, a lot of female identity is also tied to motherhood, which is great. And of course, we all have mothers.
Yes.
That's still required.
Yeah. Yeah.
And but it's not the only part of being a woman that's valuable. And so I think women are also kind of embracing that as well, especially professionally. And so
Yeah.
it
Yeah.
can be a freedom to not have to worry about, am I going to have a pregnancy that I don't want?
Yeah. Yeah.
It's good.
Yeah, makes sense.
Yeah.
So this is a question I get a lot because most of my clients are in their 40s and 50s, because that can be a time when weight shifts around and it's just where I am and it's where I lost my weight. So
Yeah.
that's been kind of my focus. And one of the big questions I get is, well, how do I even know if I'm in perimenopause? How would I even know? Am I supposed to get a blood test or?
Right. So it's a great question, and it's not clearly defined. If there was a protocol for it that was very well defined, we could take care of that in our 15-minute visit at the annual exam, But the clinical definition of menopause is no period for a year. And the average age of that is 51. So some people are younger, some people are older, but that's how it's defined clinically. So it's not an FSH level. It's not a blood test. It really has to do with menstruation because all the female hormones cycle so much that just one test in time doesn't necessarily tell you. So it's a retrospective diagnosis, but that can be challenging in people who don't get their period because they've had a hysterectomy or an ablation, or they're using an IUD or other things of why they're not getting periods. So that's in those cases, there are some testing that we can do. It's not as accurate. Perimenopause, honestly, I never heard about perimenopause until maybe the last 5 years.
Oh, geez.
We never really talked about it.
And you're an OBGYN,
I know.
so you've never heard of it.
Right.
Yeah.
So now we're thinking perimenopause is kind of an ill-defined time, 5 to 7 years before menopause, and mostly defined in the gynecology world around period irregularities. So, skipping periods, some people start getting hot flashes, that kind of thing. But I think as, people entering this space and how they're feeling, we're getting a lot more information that it's not just our uterus and our ovaries, but our whole body getting affected by it. And that's where you need more than the 15 minutes. So I actually have a 12-year-old who's just starting, a girl, starting kind of changing, her body changing. And I see it, and, as a doctor, I'm like looking at her as a curious specimen, but as her mom, I give her so much grace because I know that what she's going through, it's a lot, And perimenopause is very similar to puberty in that way, and that we need to start thinking about it. You know, your body changing physically, your brain changing, you know, your obviously reproductive life has changed. And so it can be very similar to adolescence. So remember all those fun times.
Yeah, yeah. And it's so funny that at least with puberty, everybody has a different experience. But typically, I think culturally,
right,
we warn people.
Yeah.
And we talk about it, right? Like there's ads for Tampax. So
Right.
little kids kind of know, like, oh, this is a thing.
They have classes in school,
Yeah,
about it, starting in, I think, 4th grade.
Yeah, so about 10. Yeah.
Yeah,
So that
yeah.
they know when it happens, oh, this is
Right.
that thing. Can you imagine how terrifying it would be if we just culturally didn't talk about it?
Right.
No warning, just one day, you're in the bathroom and it's like, oh my
Yeah.
God, what's happening? Am I
Yeah.
dying?
You think you were dying.
Yeah. But then that's how we handle perimenopause.
Right.
It's just like you start to feel crappy randomly, and the doctor tests to make sure it's not something else.
Thyroid.
Yeah, yeah. And then they're like, okay, you're definitely not having a heart attack. Like, okay, cool, but what is happening?
Right.
And again, different doctors are different, but I don't think they typically say, oh, well, we've ruled out everything else. It's probably perimenopause. Here's the options that are available. They're just kind of like, you're not dying, go home. Like, oh,
Right.
okay, okay. Yeah, good luck.
I feel like that's probably changing. But as you know, we talked before this, healthcare is kind of a mess right now. Even getting into somebody to talk to them, and then, being able to have that conversation is difficult.
Yeah.
Whether it's GYN or a primary care doctor, family medicine, everyone's just overrun.
Yeah. Yeah.
So a lot of times in medicine, we're trained to rule out things that are going to, kill you.
Right.
So, especially in obstetrics, sometimes I'm like, I don't know what that pain is, but I can tell you it's not these dangerous things, and so we've kind of ruled out that, and you have to, trust your instincts and come back if it gets worse. Just saying that can be helpful, but no one's really saying that to perimenopause. So, obviously I'm trying to say that, but
And honestly, that's where I would want a doctor to start is, don't be like, oh, you're having heart palpitations. Right. Well, you're 37. It's probably perimenopause. Good luck. And then you send somebody home who's having a heart attack, right? We don't want that. No. So yes, please start with ruling out all the things that could kill me. Right. But then after we've done that, maybe let the people know, like, hey, this could be perimenopause.
Right.
So let's say somebody does have that going on. They are having some weird symptoms. The doctor says they're definitely not dying, so they think it might be perimenopause. Are there any, like, let's say somebody can't go to the doctor. Are there any sort of free, low-cost things that are helpful at this time that you've seen?
Honestly, that question leads right perfectly into the other part of my business, is that all of these symptoms, when you look at data, even at the Menopause Society meeting last year, at the end of every presentation, all of these, everything about perimenopause gets better with exercise. So
what a bummer.
I know. I wish you could just take magnesium or something, and you could just sleep great and feel good. And magnesium's fine, but it's not, the miracle cure of exercise. So really that's, another thing that I know we've talked about, just how to incorporate that, and, access to time, knowledge about how to do it, expectations, all of those things, we definitely need. And luckily with YouTube and, the internet, there's lots of resources online where you can find workouts and things like that. And sometimes that's great. But it does help to have somebody guiding you through, so you don't injure yourself.
Yeah. It makes a lot of sense. Well, and the way I think about it is so if you've ever seen a little kid bowling, they have those bumpers on the side of the bowling alley.
Yeah.
So
I still use those.
Yeah, right. The idea is over time, you know, that you get better and you don't need them and the bumpers come down. And that's kind of how I think about perimenopause and about our 40s. It's all stuff that we know we should be doing: eat the vegetables, drink the water, go for a walk.
Yeah.
It's just the consequences for not doing it become a lot more severe. It's like the bumpers come down. You can't get away with what you got away with in your 20s.
Yeah.
Which again, to some degree, it's kind of good because it's pushing you to do stuff that's going to help you, you know, another 30 years from now. Yeah. So in some ways it's good, but it's just
a lot of it too, I think, is managing our expectations, which I struggle with myself, you know, that things I did in my 20s and 30s to change how my body looked and felt are not working in the same way. And, you know, the fat does redistribute more to the abdomen, a lot of changes, just like Maddie, my daughter, you know, her body is never, once she's through puberty and gets her period, it's never going to go back to how it looked when she was 8.
Oh, it's such a good point. Yeah.
And so I think we need to accept and honor that about perimenopause and menopause too, is that this is a huge transformation. And the idea that we have to get back to a place, or pregnancy, any, you know, all these back to your pre-pregnancy body, back to your, you know, we're not doing that as much to girls.
Yeah.
So we
get back to your pre-puberty body.
Yeah.
Unless maybe you're a gymnast, but yeah.
Right. And also then kind of gross, right? You're like, you don't want to look like a little girl. You want to look like a woman.
Right.
And so what does that mean to look like a woman past menopause? I think we're still defining that. You know?
Yeah, it makes sense. So yes, doing all the things we should have been doing this whole time, and also giving ourselves a little grace that
managing that expectation.
Yeah.
I have people in their 70s like, oh, I'd still like to lose 30 pounds, you know, because in my 30s I weighed whatever. And I'm like, maybe that shouldn't be the goal at this point, you know?
Yeah.
But I step on the scale every day and, you know, I do not practice what I preach.
Right.
You know, I get it. Yeah, I get it.
It's a process for all of us.
It's a process. Body acceptance is a process.
Yeah.
You know?
Yeah. Makes a lot of sense.
Yeah.
So going back to what you said about, okay, we really only know when menopause was on kind of the 1-year anniversary of it having had happened. I kind of thought that meant that any treatment I might pursue, I had to wait until I was at that 1-year anniversary. And I found that that's not correct. So can you talk a little bit about if somebody wanted to pursue a prescription, how does that work? When do you know when it's time?
Such a great question. So yeah, just like I mentioned with perimenopause being similar to adolescence, you know, there's huge hormone shifts happening. And, you know, anyone who's a person with a period that's had, you know, PMS, you can feel those changes in your brain, puberty. So, you know, it's affecting the brain, it affects your body, your periods, all of those things. So really, it's more based on symptoms. And so low estrogen causes a lot of these symptoms. And a lot of times what we do is add back estrogen. How to know who that's appropriate for, it's really personal. You know, it depends on your personal history, your family history, what you want to do about contraception, all of those things. And that's why you can't just say, oh, look, this influencer said I need testosterone and estrogen cream and then go, you know, online and get it. that makes me nervous, because there
Yeah.
are some risks. There's a lot of benefits, but there are some risks. As far as, just historically, in the 90s, we thought estrogen is going to make everybody young forever and everybody should be on estrogen no matter what. You looked at data, you could see men getting heart attacks like in their 50s. Women didn't get heart attacks and strokes till like their 60s. So we extrapolated that to say there's a protective effect of estrogen.
It's a little bit of a jump, but okay.
Yeah. Because
it's also a protective effect of like, doing what the doctor says. And
well, yeah, there's a whole thing.
But anyway,
right?
Yeah.
But after menopause, once the estrogen were low, then we were doing more male pattern health
that
issues.
Makes sense. Yeah.
And so we did a big study, we being medical people, I wasn't actually involved. I was in college, but they were going to prove it. So they did a randomized controlled trial, which is kind of like the gold standard to prove, benefit of pharmaceuticals. Designed this study, and the results came out around 2000. This is the WHI study that people hear a lot about. And it showed that there was actually in the estrogen progesterone, and especially in the estrogen only arm, there was an increased risk of heart attack and stroke in those people, not a decrease. And it was such a harm that they actually stopped the study early. And then the lay press got that and was like, estrogen's poison, the drug companies are trying to kill us, stop everything. And people just stopped all their treatment, and just felt terrible, all of these things. So it turns out it definitely was a poorly done study. I've been talking about that for years with people. They excluded people from the study design that had hot flashes because they would know automatically if they were on the real medicine or the placebo.
Mm-hmm.
They started the medicine at 60, so about 10 years, 5 to 10 years post-menopause, where already that kind of atherosclerosis and other parts of heart disease were starting. And then just other parts of the design weren't great. So now looking back, 24 years later, the community is kind of like, maybe we jumped the gun on saying all estrogen and progesterone are poison. And that this is a hormone deficiency and it's, okay to treat it. And so kind of the medical community is slowly getting back to saying maybe these hormones for women are actually a good thing. And, and in some people they're not good, but in most people there's some benefit. And so it's great because people do feel better on it.
Yeah.
And so I think, in menopause, we're definitely thinking about it more, but perimenopause too, just because hormones are kind of getting they're more accepted now and patients are more comfortable with it. It's kind of like, let's try it, in perimenopause and see if it helps, these symptoms or not. Not for everybody, but it can kind of make things more even Steven is how I tell people.
Yeah. And my experience, and tell me if this is like not a good way to explain it, and I'll stop explaining it that way. But, and not everybody has the same experience of PMS, but for me, I had a lot of sort of mental and emotional PMS symptoms. And it was usually just a day or two before my period. And it was the kind of thing where, like, let's say my husband says something and he's trying to make a joke, but it's like not funny. Yeah. And maybe kind of a little mean.
Yeah.
But it's the kind of thing that at certain times of the month, you might laugh at it, or you might say, I know you were trying to make a joke, but it didn't land. And I was kind of like a little rude. Yeah. That's how you would handle it. But that day or two before my period started, I was like, wah! Right? Yeah. Like there'd be screaming, there'd be crying. There was a lot of drama. And it was to the point where the doctor had me on 3 packs of pills back to back. So I was only psycho 1 or 2 days a quarter instead of 1 or 2 days
Yeah,
a
good.
month.
Right. I
And
love
that
that.
worked. I was
Yeah,
managing
good.
my life that way. But for me, my subjective and personal experience, once those hormones started to go down and more stay down, once I got around 50, it was like I got stuck. So instead of that evil period being a day or two, it was like weeks and weeks and weeks. And that's when the doctor finally put me on HRT. And again, everybody's different, but for me, it's made such a difference, mental, emotional. So I'm a fan.
Well, hormone-related mood disorders, are very well described. Of course, PMS, postpartum depression, all of those things. So we all know that there's estrogen receptors in the brain. I think with the rise of SSRIs like Prozac and, things like that, which also interestingly can help with hot flashes, we kind of are treating women more with those medications than the hormones. But now that there's more data about the safety of hormones in people, that if it's more effective, then that's great. That's what your brain needs.
Yeah. Yeah. And again, different for different people, right?
And the brain fog part, that's a real thing.
Yeah.
And we don't know exactly why that happens, but it definitely does. I think validating it helps a lot, because when you're having brain fog, not necessarily the mood issues that you're talking about, but you just don't remember things, you're not as sharp feeling. That can be very distressing, especially in a professional environment, your family, everything. You have so much juggling. A lot of people have older kids, older parents, their careers, themselves, and then they have this brain fog. So we're not exactly sure if hormone replacement therapy helps with that or not. But what we do know, which I think is so key to hear, is that it is temporary.
That's good.
That will get better once you get past this kind of perimenopause, menopause transition. And there's hope there that, there's light at the end of the tunnel, which is, to validate it and then to say, I can't fix it right now, but give it time. You're not crazy and it's going to get better. It's so helpful.
So I think a lot of people worry like, oh my gosh, is this early onset Alzheimer's? And again, you of course want to rule out other things.
Yeah.
But just knowing that, oh, okay, this piece may be temporary.
Hang
in there. That's really good information.
And there's a huge amount of people, sorry, Lisa, that are a huge amount of women in this phase that actually leave the workforce, which is such a big problem, because we can add a lot of value to any, industry.
Yeah.
And so as part of wellness and inclusion and all of those, almost diversity programs, including women in this age and learning about and understanding as part of what we also want to offer, different corporate places, like, hey, have your female associates come over here and we can help them through this transition, which is going to make them better at whatever work it is too.
Yeah. That's so important. That's so good. Rather than just saying, I just can't, I'm losing my mind, I gotta quit. Yeah. So is there anything that we haven't covered that comes up a lot with the clients, patients that you're seeing? Any really common concerns?
So the main menopause, perimenopause issues, metabolism, the mental health part, obviously irregular, bleeding and menstruation and what that means. And then sexual health as well. We haven't talked about.
Yeah.
That's a big one. And it's good that we're talking about it, again, not just accepting our suffering as the state, but the vagina definitely loves estrogen, vagina heart estrogen for sure. And once that goes away, it's not as stretchy. There, you can get little tears, it's dryness. And that can be very distressing, especially with penetrative sex, and then also orgasms change, and kind of the stimulation and the nerves in that area that you need are different. So even if, you're not having that type of intercourse, just your sexual experience can change. And so there's a lot of great research and things coming out, about that, and women are getting really empowered and talking about it, which is huge, with each other, their partners, and kind of advocating for themselves, and even accepting that maybe that's not something that you want to do anymore, and that's okay. There's lots of forms of intimacy. It doesn't only have to be that way, which of course we focus on a lot for reproduction, right? So that part of our bodies and our identities and all of those things changing, is something that, again, you can't really cover in 15 minutes.
Right.
You have to have trust, feel comfortable. These are things that sometimes are difficult to talk about. There's physical, there's mental. And so that's something that it's nice to have the space and acceptance to talk about those things.
Yeah. So tell us a little bit about how you do that in your practice, your organization.
All of it
alluded to it a little bit, but I know you said usually it's a 15-minute appointment. I assume your appointments are longer. So just tell us a little bit about like how you help your
So we offer a program, not just an appointment, and there's different options of time, from a 2-appointment consult to 3 months to 9 months. And it really depends on, I just really wanted it to be personal and holistic kind of program. So my initial consult's an hour. Sometimes it goes to 90 minutes if we all have the time, especially now that I'm new. And if that keeps happening, the good thing about having my own practice is I could change the initial consult to 90 minutes, and have the space to do that, which is great. So it's very consultative, and then we make a plan. I do have exam room, if we need to take a look and see some physical issues that are going on. So I can do what I'm calling midlife GYN as well, gynecology. And then the best part for me as a practitioner that I love is the follow-up, and so have an hour consultation on menopause which could never happen in private practice. And then come back in a month and we'll talk about how it's going. Because sometimes it's going great and yay, I'd love to talk about that. And then let's say, hey, how's the rest of your body? Whatever symptom that we helped. And just really kind of empower and educate and allow space and time, for people to go through the treatments and what's working and what's not. I'm also kind of able to have more tools in my toolbox than in a more kind of corporate medicine insurance-based practice where, I have a relationship with a compounding pharmacy, but I can also do more traditional prescriptions that are covered by insurance and, testing and all of those things. And it's been fun for me to, a patient has a question, I can really get into it and research it and think about it and not just panic like, oh, I don't have time to even think about this. Send her to endocrine or whatever,
Yeah.
So I get to take care of the whole person. So that may not feel like it's totally defined, but so our 9-month program is the hour consultation and an hour or half hour, depending on what the patient needs, follow up, and then bi-weekly check-ins. And then the end is a kind of graduation visit where we really go over the success plan and, what you need for the future. So if I end up giving somebody hormones, obviously once a year, we can go over that and prescribe. I'm not going to just say good luck, but that's kind of how it's working right now.
And you have a trainer that's part of your team as well, correct?
Yeah, so I have a personal trainer here, and he offers fitness and nutrition. We have a little studio, exercise studio in the office, which is great, has everything that you need. I've done a bunch of workouts here, and it can either be one-on-one, or we're trying to get some small groups because some people aren't as comfortable one-on-one. And just also, I think he's giving people plans for when, meeting once a week with them, and then for when they're not here. And so that's something that it can be part of the program, or we can do separate.
Yeah, that makes sense. And I love the idea of the small groups, because I do, again, as not to be stereotypical, but as women, we tend to be very like community oriented. And to have other people that are going through the same thing, I would think it's kind of permission, if you meet that way, to talk about it. And I think the talking about it is so helpful. Back to what you were saying about validation of like, okay, it's not just me. Other people are on hormones and
Right. Not everybody here is, 20 former NCAA athletes or something.
Right. Yeah. Yeah. That piece as well of, sometimes the gym can be very intimidating depending upon where you are. A lot of like big,
a lot of teenagers culture in the gym I was going to, like, I don't want to deal with this here as well.
Makes sense. It makes sense. So,
but
all right.
I've even been doing some workouts with the groups, which is fun, workout with Dr. Colthran.
Yeah, that's nice.
It's great. I mean, I really think doctors should embrace fitness and nutrition more. It's just a resource, and, insurance doesn't really allow you to have time to do that. So, it's just, as far as access to care, it's too bad. Like you were saying, what can people do for free? But it is just how the system is now. You have to kind of get out of that in order to add, value add other things. So
that makes sense. So if somebody is listening to this and they're like, oh yeah, that's exactly what I need. Somebody that will actually let me go down like my list of questions and, all of my aches and pains and weird things. And who can work with you, and how do they find you?
So right now I'm just based in Virginia. I only have a medical license in Virginia. I know we talked about that earlier too, about finding out some different options, which I'm working on. But our website is menostart.com, MENO with a dash, START.com, and all of it's laid out there. You can email me through there. I am listed on the national, or it's North American Menopause Society or Menopause Society directory as well. But really the website is the best way.
Makes sense. And for all the folks that are virtual. Yeah, for all the folks that are not in Virginia, that website you mentioned is a good resource to hopefully find some providers that are a little more menopause informed.
And I think it's happening. Like, this space is definitely growing, which is great. The market's ready. A couple years ago talking about this, I was like, do I have enough to offer? To only concentrate on this? But more research coming out, obviously pharmaceuticals, but also other options. And so there is enough to support these types of practices. And so I think it's going to be, people in other states are going to be able to find things. Somewhere.
Yeah. Maybe it's the next big thing. So
I hope, hey, we're a lot of people that need it, right?
Absolutely. Well, thank you so much for taking the time, and for all of you who were watching. And if you want to find me, my specialty is coaching women in this age range, this transition, helping them implement some of these healthy habits, getting into the behavioral piece. Again, some of the stuff that even a doctor that'll talk with you for an hour and a half might not have the time to dig into. That's my specialty. And my website is just lisaduke.net. I offer a 4-month program where we meet once a week on Zoom from anywhere in the world and really dive into what's driving the behaviors that are getting in your way and how to implement those newer, more health supporting behaviors. So lisaduke.net. All right. Thank you so much
Thank you,
for your
Lisa.
time. I really appreciate it.
Have a great day.
Take care.